Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic. Today, we will be covering rheumatoid arthritis, which is part of the Rheumatology module of MRCP. So, what is rheumatoid arthritis? It's the most common chronic systemic inflammatory joint disorder with a symmetrical deforming polyarthropathy pattern in its clinical features. Rheumatoid arthritis can affect anyone worldwide, but is more common in females than males with a 3-to-1 ratio. The age of onset is typically between the ages of 40 to 60 years, but of course it can occur in individuals who are younger and older than this. Its cause is unknown, but we do know that genetic and environmental factors play a role. In addition, it's associated with the HLA-DR4 subtype, as well as a history of smoking. As we said before, this is a symmetrical small joint polyarthropathy associated with significant early morning stiffness. And this is quite obvious when a patient first presents, for example, to the early inflammatory arthritis clinics. Disease onset can usually be insidious in most cases, but also intermediate in its timing, as well as acute onset. Other patterns of onset, which are rarer, are palindromic, so a sort of relapsing remitting pattern, systemic, which means it does present with extra-articular features at onset, as well as polymyalgic, which is a PMR onset type RA, usually seen in older people. Here we have the 2010 ACR-EULAR criteria for rheumatoid arthritis, which is quite a good aide-memoire for remembering the clinical features of this condition. So as you can see, it is based on the number and size of joints affected, as well as the antibodies, which we'll talk more about in detail in the slides to follow, as well as the acute phase reactants, so this is CRP and ESR, as well as the duration of symptoms, which is typically greater than 6 weeks. So coming to the investigations for rheumatoid arthritis, we do find that rheumatoid factor is positive in 70% of people with RA, but as we will see, this is by no means a specific test. Anti-CCP antibodies are more specific and in fact 98% specific for rheumatoid arthritis. Anti-nuclear antibodies are usually tested when we are investigating people with possible rheumatoid arthritis, as well as connective tissue disorders, which will be covered in another lecture series. But this ANA test is positive in 30% of patients approximately. It's also a good idea to test for other antibodies associated with other connective tissue diseases in these patients, as the rheumatoid arthritis pattern can be part of a wider connective tissue disease. Inflammatory markers are also tested, and these typically show increased platelets, as well as ESR and CRP. If a patient presents with a hot swollen joint, of course, this is an infective cause until proven otherwise, but should it be due to rheumatoid arthritis, it would show a typically inflammatory picture with white cells of around 5,000 to 50,000 per millimeter cubed, but no other definitive features really to diagnose rheumatoid arthritis. So coming to rheumatoid factor, which we mentioned previously, this is an IgM against the Fc fragment of IgG and is present in approximately 75% of patients with rheumatoid arthritis. In approximately all patients with extra-articular manifestations, which we'll come to later, rheumatoid factor does tend to be present. It is worth noting that it's positive in about 5% of the general population without RA and 15% of the general population aged over 65 years of age. So as you can see, it's not a specific test for rheumatoid arthritis at all. On the other hand, anti-CCP antibodies, this is present in 70% of patients with RA and is more specific than rheumatoid factor. It is associated with more specific disease and may be present years before clinical disease onset. So just to summarise, rheumatoid factor can be seen in plenty of other conditions other than rheumatoid arthritis. And as you can see, this is a really wide range of conditions, ranging from connective tissue diseases such as Sjögren's, dermatomyositis, all the way to certain forms of infection such as hepatitis C and other conditions such as malignancies. Anti-CCP antibodies, on the other hand, do tend to be present in people with rheumatoid arthritis, but occasionally seen in people with lupus, Sjögren's, as well as a specific form of hepatitis type 1 of the autoimmune type. Coming to imaging findings, so when patients with rheumatoid arthritis or suspected rheumatoid arthritis are assessed in dedicated clinics such as early inflammatory arthritis clinics, x-rays are usually taken, usually off the most commonly affected joints, which tends to be the hands and sometimes the feet, but sometimes the x-rays are taken of other affected joints such as the neck and other larger joints, as well as the chest if we want to start immunosuppression therapy, which we'll come to later. It's also worth considering joint ultrasound to assess for synovitis, which is present in patients with rheumatoid arthritis. In these images here, you can see that there is severe subluxation of the metacarpophalangeal joints, which are commonly affected joints in rheumatoid arthritis. A good aid memoir for remembering the features of X-ray findings in rheumatoid arthritis is the ABCDEs approach. So A, looking at the alignment, which is usually abnormal, and we wouldn't normally expect to see any ankylosis, which is seen in other forms of inflammatory arthritis, which will again be covered in another lecture series. B, for bones, so there may be osteoporosis, but no osteophytes typically, which are seen in osteoarthritis, as you will have heard in a previous lecture. C is for cartilage, which is really talking about the loss of joint space in the weight-bearing joints, but no calcification is usually seen. There are deformities, which we will talk in further depth in coming slides, and these tend to have a symmetrical distribution. For example, if you look at the hand changes, and certainly if you look at those x-rays we saw on the previous slide. Erosions, which tend to be in marginal distribution. And finally, S for soft tissue swelling, which includes nodules, but these don't have any calcification. Looking now at articular manifestations, so these are really the specific clinical features which we find on examination, and these typically would be things you would look out for example, in a PACES examination. So looking at the hands, we tend to see swollen small joints, particularly the MCP joints, more so than the PIP joints, and usually there is very little or no involvement of the distal interphalangeal joints. We also see ulnar deviation, swan neck deformities and boutonniere's deformities, which we will come to on a next slide, but also you can see here in the image which shows you exactly the difference between those two deformities. The Z-thumb deformity and rheumatoid nodules, and this is where it's really important to particularly inspect elbows where these can show up. Other articular manifestations can involve the C-spine in up to 30% of patients. And in rare cases, we do see involvement of the hip and the distal interphalangeal joints. Just speaking more about rheumatoid nodules, these are present in approximately 5% of patients in the early stages and 20 to 30% of patients in the longer term. We do find that rheumatoid factor tends to be positive in these patients. The nodules can be subcutaneous or visceral, and a typical place for this would be the lungs. If they are examined under histology, we find that they have a central fibrinoid necrosis with surrounding palisading macrophages and a fibrous capsule. And here in the image we can see a typical rheumatoid nodule at the elbow. We have talked about extra-articular manifestations, and in these patients rheumatoid factor does tend to be positive, and extra-articular manifestations can affect approximately 30% of patients. The arthritis does tend to be more severe as well. As we can see from the diagram, extra-articular manifestations can affect pretty much every organ system of the body. So common ones would be involvement of the lungs. So rheumatoid arthritis ILD is a very well characterized clinical manifestation. We can also see aspects such as vasculitis type rashes and the rheumatoid nodules we've already mentioned. In the investigations, it's important to look for aspects such as anemia and a high platelet count, as well as a neutropenia that may indicate the onset of Feltes syndrome. And there's various ways in which the kidneys and the nervous system and also the gastrointestinal system may be affected. Rheumatoid arthritis disease activity is really important to measure when patients are assessed in clinic. For rheumatoid arthritis, this is known as the DAS-28 score, or Disease Activity Score for 28 joints. This counts the number of swollen and tender joints, plus the ESR or CRP, as well as a patient self-assessment score. High disease activity is denoted by a DAS-28 of more than 5.1. From 3.2 to 5.1, it's denoted as moderate, and less than 3.2 is low disease activity. If the DAS-28 is less than 2.6, the patient is said to be in remission. Taking all of that together, ultimately, diagnosis remains clinical, reliant on a thorough history and examination, supplemented by the investigation findings, including those we have discussed. Coming to the management of rheumatoid arthritis, this really relies on a multidisciplinary team approach, as well as pharmacological and sometimes surgical management further down the line where necessary. The multidisciplinary team approach is really worth noting in rheumatoid arthritis. Allied health professionals such as physiotherapists, psychologists, occupational therapists, as well as other specialties such as respiratory and liver specialists, orthopedic surgeons are really important in caring for these patients. Pharmacological approaches can be divided into first line and second line approaches, first line being disease modifying anti-rheumatic drugs, as well as simple analgesia. And second line drugs involve biologic agents, as well as the newer targeted synthetic drugs as well. These can be supplemented with the use of corticosteroids, which are often used when a patient first presents and if they're flaring, and indeed further down the line as well if they have flares in their disease. Surgical approach as well is sometimes needed, for example in severe joint damage or for joint replacement. So let's talk a little bit more about disease-modifying anti-rheumatic drugs, or DMARDs for short. The aim of these is to suppress an overactive immune system which is responsible for rheumatoid arthritis. They work in a time frame of weeks to months and should not be used for immediate symptom relief. For this, they can be used with non-steroidal anti-inflammatories or steroids, of course depending on the patient's other comorbidities and pharmacotherapy. The factors influencing choice are wide-ranging, but does depend on the stage and severity of their condition, as well as the side effects versus the benefits and patient preference. Comorbidity should also be taken into account here as well. Their effect is to reduce the number of swollen and tender joints, which can then hopefully lead to reduced pain and stiffness. They also aim to slow radiological progression and reduce inflammatory markers. And overall, as you can tell from this, it should hopefully reduce the overall disease activity score. Given the immune modulatory nature of DMARDs in order to suppress rheumatoid arthritis disease activity, it does follow that strict monitoring requirements are in place, particularly when a patient is first being established on one of these drugs. The most common DMARDs in use for rheumatoid arthritis are methotrexate and leflunomide, which have a similar mechanism of action, sulfasalazine, and hydroxychloroquine, which is the least immunosuppressive of these four. Monitoring for the top three in this table include full blood count and liver function tests, as well as blood pressure for leflunomide as well. In the case of hydroxychloroquine, as per the joint British Society for Rheumatology and Royal College of Ophthalmology guidelines, ophthalmological screening is required after 5 years of use, but patients are encouraged to do yearly optician screening with OCT during their time on this drug and just before starting as well. Coming to biologic therapy, which are used when a patient either is unable to tolerate or is not able to have their disease controlled by the use of DMARDs alone. The most common biologics are tumor necrosis factor alpha blockers or TNF alpha blockers, but there are many others now which are in use as well. Before starting a biologic drug, it's important to counsel patients on adverse effects, and these include the risk of infection and malignancy, particularly reactivation of latent TB and reactivation of viral hepatitis. So patients are tested for these infections prior to starting, as well as HIV. It's important not to use live vaccines with biologics. In the case of anti-CD20 use, which will be more evident on the next slide where we talk about individual drugs, the risk of progressive multifocal leukoencephalopathy should also be discussed. And in very rare cases, multiple sclerosis is also a risk, particularly with the use of TNF alpha agents. So here we have a summary table of the most common biologic treatments that are used for rheumatoid arthritis. So as you can see at the top of the table, we have several TNF alpha blockers, which is followed by IL-6 receptor antagonists, IL-1 receptor antagonists, which is anakinra. We then have the CD20 antagonist, rituximab, and finally abatacept, which is a CTLA-4 inhibitor. So as you can see, there is a wide range of targets which are employed in the treatment of rheumatoid arthritis. So now we will consolidate everything we've learnt so far by looking at some questions, and these are typical and reflective of those which may appear in the MRCP Part 1 exam and possibly in Part 2 as well. So the first question: a 35-year-old lady with rheumatoid arthritis presents to her GP with recurrent urinary tract infections. She is prescribed a short course of trimethoprim. 2 weeks later, she presents to hospital with a white blood cell count of 1.5 times 10 to the 9 per litre, a haemoglobin of 65, and platelets of 100. Which drug has she been taking for rheumatoid arthritis? So you may already have some ideas, but let's look at the answer. So the choices here are sulfasalazine, hydroxychloroquine, abatacept, methotrexate, and prednisolone. So this particular interaction is one that's really worth knowing for the MRCP exams, as it can commonly come up as a multiple choice question, but also in clinical practice, as this is quite a common scenario, particularly if you are working in general medicine or rheumatology. The correct answer here is methotrexate, and this is because of the increased risk of bone marrow suppression when used with trimethoprim, so they should not be used together. Going on to the second question, which of the following drugs works by blocking CD20? So this is something we did cover in a previous slide, and the answer here is rituximab. And the final question, which of the following statements is true? So these are the choices. Rheumatoid factor is more specific for rheumatoid arthritis than anti-CCP. Rheumatoid factor is IgM against IgG. Anti-CCP is usually positive in cryoglobulinemia. Anti-CCP is positive in 90% of patients with rheumatoid arthritis. And osteophytes are commonly seen on X-rays in people with rheumatoid arthritis. So if we look at each statement in turn, as we discussed, rheumatoid factor is not more specific for rheumatoid arthritis than anti-CCP. Anti-CCP is the more specific antibody. In this case, answer B is the correct answer. So rheumatoid factor is IgM against IgG. Just to look at the other answers as well, which are incorrect. It is rheumatoid factor that's usually positive in cryoglobulinemia. And anti-CCP antibody is positive in approximately 70% of patients with rheumatoid arthritis. And osteophytes are an X-ray feature in people with osteoarthritis, not rheumatoid arthritis. So there we have the correct answer, which is option B. So that's all for today. Thanks for listening to this episode of Bite-Sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear from us about in future, and we look forward to seeing you for our next episode on the Bite-Sized MRCP channel.